Good afternoon, ladies and gentlemen. Welcome to the CHSRF On-Call. I would like to remind you that this conference call is being recorded. At this time, all participants are in a listen-only mode. For those connected by telephone requiring assistance by an operator during the call, please press star, then 0. Web participants requiring support should select one of the tech support options at the bottom of your screen. I would now like to turn the meeting over to Stephen Samus, Vice President Programs at CHSRF. Please go ahead, Mr. Samus.
Thank you. Hello and welcome to CHSRF On Call, an interactive series by the Canadian Health Services Research Foundation, which brings together policymakers, healthcare leaders, researchers, and others to be part of a dialogue about ways to improve healthcare for Canadians. As you heard, my name is Stephen Samus, Vice President of Programs here at CHSRF. It's my pleasure to welcome you to today's call, where we're exploring ways to optimize the role of nurses to improve healthcare efficiency. We're very pleased that joining us today are Dr. Gina Browne, Professor of Nursing at McMaster University and author of the just-released paper Better Care, an Analysis of Nursing and Healthcare System Outcomes, which can be found on the CHSRF website, and Scott Robertson, Chief Nursing Officer for the Government of the Northwest Territories. Today's call will begin with brief presentations from each of our speakers, and then we'll open up the lines for a live question and answer period when we'll take questions from the audience. Instructions for asking questions will be provided after our speakers have finished. So we will hear from both of our speakers now, and it's my pleasure to hand over the floor to Gina Browne.
Thank you, Stephen. It is a distinct privilege to have this chance to talk to, I think, so many nurses, but other healthcare providers, about ways to optimize the role of nurses to improve efficiencies. And, of course, I think that has to do with transforming the process and the way we deliver all of our care. Clyde Hertzman said we must depart from the habits of mind that have characterized our usual thinking. And some of the things that characterize our usual thinking have to do with assumptions. Wicked problems or wicked questions are used to expose the assumptions held about an issue or a situation by members of a group. And I'll move right on to the next one because of time. The general assumptions we have about what is causing all the rising healthcare costs is it's about aging. No, it's those people with chronic disease. No, it's those baby boomers. No, it's the technological advances that are keeping people alive. Well, it's all of the above. Well, I'd like to examine some data to help you see the context and behavior of what really might be going on using some Ontario and Winnipeg data. The Ontario population is 13 million people, and you should know that 1% of this population, or 130,000 people, use 49% of hospital and home care services. Now, that's mostly hospital because Ontario does not fund home care services very much. Further, 5% of the population, or 650,000 people, use 84% of hospital home care services. So there seem to be a few that are generating a lot of cost. Looking at Winnipeg data, Mr. Dupé looked at less frequent, and very frequent users. Of course, I think the frequent and the very frequent are awfully frequent, so I'm looking at those two columns together. But you'll see that there's very few people. There's a great deal of people, the 103,000 people that use the emergency room less often, but very few more that use it frequently and very frequently. Again, the issue of a very small number consuming lots of resources. And what's noteworthy about, to critique our present model of care is these users, the less frequent users, or the frequent and the more frequent users, had 66 and 71% previous visits, greater than 7 times with their primary care physician, or the primary care offices, and then greater than 3 times with their primary care physician, 46 and 62% respectively. And again, visiting physician specialists, greater than 3 times, 48, 38% respectively. Hospital admissions, again, very much higher among the frequent and very frequent users. They were previous emergency department visits in the previous year, greater than 7 times. Look at that, 70% of very frequent users. And so we have the same pattern of a very few generating most of the cost. And you might wonder, well, were they the poor or who? Yes, the frequent and very frequent are in the lowest income quintile. But what are they presenting? Yes, it is chronic diseases. Okay, one could say at a glance. But when you go down and look at heart disease, for example, it trails off in the very, very frequent user. Look at ischemic stroke. It goes up, but then it trails off in the very frequent user. And I suspect something other than this particular disease is what's generating the use. So looking more closely at that same Winnipeg data, you see that it is these mental illnesses of anxiety, depression, dementia, personality disorders. That is the thing that those are the aspects of the comorbid presentation of illness that is driving what I call the help-seeking behavior. So there is a new thought about principles of causation in social epidemics, and it's called the tipping point, the boiling point about where massive modern change creates what happens. It says there are contagious behavior or ideas that stick and make an impact. There is the law of the few that very few people or little causes have big effects of geometric progression and out of proportion, not a proportional or gradual increase. Both contagion and the few happen in a hurry, dramatic change. Like we say, the baby boomers, the power of contacts, or the deterioration of Ontario's financial rating. There's different ways of tipping. It could be that because of the stimuli, aging, and technology. It could be because of the way a disease transforms. It moves from acute to chronic. It can be because healthcare is increasingly consuming most of our budget, and now Ontario at least has a financial downgrading. These are different ways you can tip. But let's just look. How could we create a positive social epidemic? Let's look at the Arab Spring. There was a contagious message of social injustice, and it stuck. Suddenly, a man set himself on fire. The youth rebelled, and the Arab Spring spread. We need new contagious messages about patient needs in health care, and some of those would be, for me, listen, public, a very few people use the most of our expensive resources. Alternatively, acute and episodic on-demand medical care is a very poor match for some of our chronically ill, particularly those with comorbid mental issues. Alternatively, better proactive nurses providing continuity of care is needed for the chronically ill and the more vulnerable who are the 5%. Let's just look at transforming models of care, and so as not to be a threat to physicians. The right-hand column, the resolved citizen and the no-problem citizen, that's 95% of the population. And they generate 16% of hospital or home care budgets. The present model of physician on-demand acute care is probably okay for that 95%. What is needed is a different model for the recurrent problem citizen with a high degree of vulnerability or the resistant problem citizen whom we don't reach. That accounts for the 5%, consuming 84% of hospital home care budgets. So these people over here, the 5%, are very well known to physicians, so it's not that the medical problem is probably the issue. We, as was announced in my introduction, looked at the comparative effects and costs of models of care for chronic disease, and we found in this matrix that most of high-quality studies ended up being more, in box number 1, more effective, and only one was in there, more effective and more costly. A majority of them were in more effective and equally costly, more effective, less costly, box 8, equally effective, less costly, and those that were physician replacement models of nursing practice are equally effective and equally costly. So, promising models of chronic care for nurses should be professionally led, and I believe nurse-led, should be targeted at people, and I'll explain who they might be in a minute. It should be proactive in outreach aimed at things that determine people's health. For the chronically ill or those in chronic circumstances, we should supplement the areas of vulnerability and the areas of care provided now by physicians. It needs to be comprehensive. We need an interdisciplinary team, and we might use the phone or alerts to help. Who are the priority chronically ill? They would be hospitalized in the past year or recently discharged, used the emergency department in it last year or recently discharged, lives alone, cognitive impairment, a mental issue, living in a long-term care facility, and poor. And so I'm suggesting that primary care physicians might look through their caseloads and find that 5% and assign a nurse to look after that group of people that are more than well known to them from a medical point of view. Steps for large-scale transformation would be, let's increase the urgency for change. Let's build on the powerful guiding team and get the vision right. We need to communicate for buy-in that the MD model is okay for 95%, so let's remove that fear and sense of competitiveness. But the nurse-led model is more appropriate for our 5%. We need to empower action, create short wins, and don't let up, and make the change stick with a contagious message. Our closing comment is changing behavior is less a matter of giving people analyses to influence their thoughts and more about helping people see the truth to influence feelings. That is the heart of change. And we need nurses to get back and recover and express their passion for change. Thank you. Now over to Scott.
Thanks, Gina, and I'm very pleased to be speaking to my colleagues from coast to coast to coast from Yellowknife, Northwest Territories, Canada's sunniest capital city. The Northwest Territories has a long history of advanced nursing practice, and I'm going to differentiate between sort of the advanced role of nursing in general and nurse practitioners because they're not synonymous, even though we do have both that exist in our system. The first health center run by nurses in the Northwest Territories was in Fort Providence in 1867, so the year of Confederation. The Order of the Grey Nun set up shop and started delivering primary and acute care services to people in the Northwest Territories. Since then, this care has evolved, and people have looked at our model, and it became more formalized through a number of processes, and we were looked at for the development of various things, including the nurse practitioner model. And we actually didn't get legislation for nurse practitioners until 2004. Most of the country came on board around that time and formalized that advanced role of nursing, especially in the area of making the diagnosis and ordering diagnostic tests. So for our registered nurses that work primarily in community health settings who are not nurse practitioners, they function in I'm hesitant to say an advanced role. They function in a more full role within the nursing scope of practice. And there are a couple of things in our legislation and in our rules in the North that are probably a little bit different depending where you go across the country. But one of the things that has really helped us is that our legislation says less instead of more. One of the things it allows us to do is it passes the responsibility of some of the more complex issues like drugs back to the association. The association then passes it on to the employer, and this is just a little excerpt from the bylaw. And it allows a registered nurse, note this is not a nurse practitioner, to dispense drugs. This is different than prescribing. They can dispense based on approved clinical practice guidelines that are approved by the employer. So a registered nurse in the Northwest Territories can use an approved employer clinical practice guidelines to administer drugs for certain conditions. This has been very important for us because it has allowed our nurses to then have a much broader scope than what they may have in other parts of the country. So that's just an example, a bit of a starting point that we'll come back to and talk about in a moment. About 3 or 4 years ago, the CNA came out with this report, and one of the biggest recommendation they made was if we want to address the shortage of registered nurses in the future, we have to start making sure registered nurses are doing the work of registered nurses. On average, you spend 40% of your day doing non-nursing tasks, and I am a prime example because I was here this morning typing up minutes from a meeting I was at and doing some filing. Things aren't really core to my function, but someone needs to do that. By shifting that non-nursing work away from nursing and focusing on what we do best, just like how we should be doing this with every practitioner in our system, is one of the best ways that we can better utilize people within our system and improve the care that we deliver. I'm going to give you 2 examples now about some things that have happened in the Northwest Territories recently that I think are of interest, and I think that you might find a good example. 2 of our hospitals in the emergency department had the same problem, how to address the wait time for patients who present who need first-line analgesia. So they need either acetaminophen, Tylenol, or ibuprofen, Advil, Motrin for fever, pain, whatever their need is. One hospital took the approach of, let's ask the doctors what we should do about this. The doctors said, okay, well, we'll develop a medical directive for nurses to follow, like an order. The other hospital said, wait a minute, this is within nursing's responsibility because we can administer medication based on guidelines, so let's take the lead on this. And they wrote a nursing clinical practice guideline for the administration of first-line analgesia. How this is, the outcome was fairly similar. The difference is that the nurses, the hospital where the nurses took the lead, felt very empowered, and since then they have implemented at least 6 fairly important clinical practice guidelines that are nurse-led, where traditionally those would have come as physician orders or medical directives. And now the physicians turn to the nurses to say, here's an issue, how should we solve this? So I think it's very important to remember for nursing to take the lead and look at how they can provide the solution rather than waiting to be told how to fix the problem. The Northwest Territories covers a very large part of Canada's landmass. We have 33 communities, and very few of them are connected by road. In fact, I think only 9 of them have year-round road access. We rely heavily on medical transportation. About 4 years ago, there was a small report that was done by one of our emergency physicians here, and one of the things he said was about 25% of all patients that arrive by medevac to the emergency department from a community health center are discharged within about an hour or 2 of arrival. The problem with this information, this is not how it was intended, but how that was interpreted was, obviously the nurses don't know what they're doing if they're medevacing all of these people and they're just being discharged from the hospital. You would think after 4 years that we would have been able to counter this message. One of my coworkers was at a meeting last week, and one of the head of an NGO said to her, if the nurses weren't wasting all the money on airplanes and flying people around unnecessarily, there might be more money left in the pot for us to deliver the rest of our social programs. So this message was completely misinterpreted, but it's still out there and it's still pervasive. And despite us trying to play catch-up to say, actually, the data that we have, and when we did more analysis, shows that these transports are entirely appropriate and nurses are using the system appropriately, it's not how it's interpreted. So with those recent examples, I want to leave you with a few messages about the now what, and Gina spoke to these, I think, primarily in her presentation. Number one, nursing has to be first to define the data that defines the value of nursing. If we wait for someone else to do it, we play catch-up, and we're never going to get there. We're never going to win that. Aim at a valuable target. Pick a big win. Like pick something that you can attack, where you can show your value, where you can have an impact, and that it will be meaningful. And the third point, which sort of speaks to the second point, is make sure that your value, the value of nursing, is clearly articulated in a visible, tangible, quantitative way, because we speak of nursing values, which are very important, of being collaborative, being interdisciplinary, being patient-centered, being holistic. Those are very important for us, but it's very hard to translate those into value for the system, particularly when there are so many pressures financially, politically, and otherwise for us to be improving the system. So when we speak about nursing, we need to translate those values into actual value for the public to see and for decision makers to see. When we throw out numbers, like when we say if we increase RN care by so many hours per patient per day, it will reduce the nosocomial infection rate by 3%, that doesn't resonate with people. When you say if we have this nursing guideline in the emergency department, it will reduce wait times by this many minutes, it will free up this much time of doctors, it will save this much money, that has a much more powerful impact. And I think Gina's presentation talked about that. So remember, you have the ability, wherever you are in the system, to make an impact. But I think that what we have not done effectively across the country is to focus on those areas where we can have that impact and really demonstrate our value. So there's my call to action. Thank you.
Thank you very much, Gina and Scott. Excellent presentations. We're now going to open the floor to the audience for questions. There are two ways you can pose questions today. First, you can submit your questions electronically using the questions box located on the bottom left of your screen. Or for any participants not connected by computer, you can ask your question verbally by pressing *1 on your touch-tone phone. When asking a question, we'd appreciate it if you'd please identify to whom the question is addressed, and please try to ask only one question at a time. One question that we have for you, Scott, is can you provide other examples of where the Northwest Territories has used nurse-led initiatives, where other jurisdictions used physician-led models, and what were the outcomes?
Ontario, don't feel like I'm rating on you, but I'm going to a little bit. During the 2009 H1N1 pandemic, we were one of the first jurisdictions, but also I think one of the most successful jurisdictions in rolling out our immunization campaign. Because it was nurse-led, we pushed the vaccine as far out from physicians as possible because we needed our physicians to look after sick people, and our physicians were on board with this. We recruited nursing students, LPNs, everyone we could to do that. And even within nursing, we realized that was such a valuable resource. We hired logisticians to babysit the vaccine, maintain the cold chain, do all the documentation, and put nurses in charge of educating the public, managing any adverse outcomes that came from that. The outcome was that we ended up with a very successful campaign. We immunized a very large percentage of our population in a very short period of time. After all of the reports came in from across the country the following year on evaluating the success of the campaigns, the report that came out of Ontario said they felt their mistake was not giving the vaccine to more physicians to give out in their offices, and I could not disagree more. That is the wrong use of a physician resource. In the Northwest Territories, I think last year, I don't think there was one vaccine that was administered by a physician. Ontario, I don't have your numbers, but I think it's somewhere around 60% or so of your vaccines are administered by physicians. Is that really the best use of their time? I don't think so.
Thank you. Very, very interesting example, actually. And Gina, you talked about how social change can occur and some of the issues around how to make it stick. How do we continue to address some of the kinds of comments that Scott was passing on in his presentation around the role of nurses in care, and relating that to the kind of data that you showed around who's using the healthcare systems across the country and what their conditions tend to be? How can we encourage more the spread, picking up from Scott's point, how can we encourage more the spread of nurses and their scopes of practice across the country?
I would like to have strategic alliances with all the journalists in the country of major papers. It's, these data that I'm talking about, the 1 in 5%, comes from a paper from the Ontario Hospital Association and the Community Care Access and one other, and they had a paper called Advice to the Government of Ontario. Nowhere is that in the public media, for example. So I think the biases that stick, as Scott has referred to, and the others, the lack of information that persists despite the information that we really do have, needs to be out in the public domain. So I wouldn't even be for publishing articles. I would be being in the paper every other day.
Right. Excellent point. Thank you. We do have a question here from Rhonda. We've struck a small working group, all staff nurses and the CNE, to examine how to optimize the role of the RN in acute care. Any suggestions on where to start? This is for either Gina or Scott or both.
Well, I think that Gina hit the nail on the head when she showed the data about aim for that big population, aim for your high users, because certainly when I've worked in the emergency department, it's those we say the frequent flyer, but the people that come back for services, obviously there's a need that's not being met, and I would argue that our physicians get frustrated with having to look after those clients, whereas I think nursing's in a better position to identify some plans in place to address that. But I'll turn it over to Gina for more comment.
Well, couldn't agree more, Scott. You see, the people in critical care who have been there before, or in the emergency room before, who keep coming back. And, of course, they're in critical care because of a certain organ failure or body failure. But the real reason, for example, I'll use my study of adolescents between 10 and 17 years of age, randomly sampled from a roster of a health service organization, and we showed that if there was no problem, if the child had no psychiatric or behavioral problem, they consumed $300 per child per annum. If they had one or two behavioral psychiatric problems, they consumed $600, double the cost. And if they had 3 to 5 disorders, they consumed $2,800, almost 7 times the cost, 7 or 8 times the cost. Now, the point of it is these youth engage in high-risk behavior. They use the emergency room a lot, and the underlying mechanism or problem is never addressed. I think a nurse-led group of people would address the comorbid social and emotional factors that keep people's deterioration persisting or their recidivism persisting.
I think what also would add to the question is don't try to get it perfect. Just start. Do something, even if it's one little thing you do. That success will build and snowball. And Gina talked about the tipping point and the things that make things stick. And I think I see so many projects that get bogged down in trying to make it perfect rather than trying to make progress.
Absolutely.
Thank you. Yeah, we have another question here from Jenny. What are the real barriers to implementing nurse-led models of care? We've known the evidence for many, many years. We are seeing an interesting, I think, by Gina, different constellation of the evidence here, very compelling evidence that you've brought forward. But the call to action isn't new. And so what are some of those barriers, and how do we move those forward to match care to need?
I think it's imperative on the funder, governments, provincial, and even federal, if they want to get into it. But the governments do control the healthcare purse strings, and they have persisted in funding a physician-led model and being influenced by physician-led threats that they'll have to move out of the country. I think we have had a physician-led model of care for centuries and an insured physician-led model of care for 60 years. I think it's time the government launch through funding these nurse-led models, where it's funding to a nursing organization who in turn then works with a physician on the team.
I'll add a couple comments to that. I think number one is, and the example I gave of the tale of two hospitals, I think very often nurses wait to be told what to do versus taking action. Don't wait for someone else to tell you to do. You figure out what it's going to be and then go and do it. The other piece of this is anyone who works in policy knows it's very difficult to recruit people to work in health policy who are actually interested in working in health policy. And the comment I get from nurses is they say, I don't, that bores me. It's not interesting. I don't really care about that. I want to focus on patient care. But I think we have to shift our attitudes in understanding how the system really works. And even within your own organization, like Gina spoke about very broad government measures and funding models, but within your own hospital or health center, whatever organization you're in, figure out how decisions actually get made. Is there because having a very intimate understanding of that will help you advance your whatever initiative it is. Is there a nursing advisory committee, a medical advisory committee, a joint advisory committee? Who makes those decisions? Is it the CEOs from your region that get together and vote on initiatives? Does it go through a committee first? So understanding that very clearly, so you know who to go to and who you have to ask if you need that level of approval. That I think is a thing we always tend to ignore, and I think that's a place where you can have downfall.
Great. We have another question here. This one from Daryl, and it's for Scott. The question is, the problem in my ER is due to a recent patient flow study. The nurses are expected to take blood and do EKGs. This seems to go against what we are talking about today here. I have tried exhaustively to avoid this from happening because I tend to agree with what this webinar is promoting. Any idea how to reverse this train of thought?
It's a tough one because, and I don't know the context of your emergency department. Here in Yellowknife, where I've worked in the emergency department, we have about 50,000 visits a year. It's about 60 in a 24-hour period. The problem with that is during our peak times, it would be great to have that extra help where we could shift that off of nursing. But when it's not busy, you would have, if you had an EKG tech or someone else doing that sitting around, it's it wouldn't be economical to have that extra person. We've done some across the north. We've done a few time motion studies over the years that we've looked at, and the challenge with them is that there's so much variation in the day. It's hard to bring that together to say here's the answer.
My own view too, building on that, Scott, is that we shouldn't view drawing blood or doing EKGs as a single intervention. Nurses do lots of things when they give a bath. They're doing assessments, reassuring, and assessing the emotional status, taking more history, finding out where the people come from. So I think it gives them an occasion to lay on hands, if you will, in order that they legitimately can get more information. I'm not sure it's a bad thing. I'm more opposed to Ontario policies where nobody in the ER can do anything until the physician has seen the patient. That is really, really something.
We have another question here from Joe. It's for you, Gina. What have you found to be the ideal model of care on a medical, surgical, or acute care unit? For example, all RN, RPN mix, or other mixes?
It's been established over and over again in very good studies that an all RN model pays for itself in the same year by reduced nosocomial and antibiotic-resistant infections.
Another question here, maybe this one for Scott. This is from Audrey. We've had a very difficult time trying to maintain frontline nurses on a policy review team. So I guess the question might be, is there a sense of why that happened?
Yeah, it's not unique to you. Even in the north, we have, I think, 550 nursing positions across Northwest Territories, and I think that the same 7 nurses sit on almost every single committee that there is. It's very difficult to get people interested in that. My suggestion to you might be to pick something that there's some where they'll see the return on the investment faster, like reviewing a policy about changing bed sheets might not be interesting, but if there's that opportunity to be involved with something where you can actually see change, I think that goes for a lot of political, I use that word with finger quotes. You can't see me making them at my desk here. But that sort of participation, because you don't ever see the change because of how long that takes. So I'd say try starting with something where there is interest in how that group can make a difference, because then you'll get buy-in because there's a vested interest for them to actually see that change happen. It is very difficult, and the other thing that I may suggest, although I haven't had much luck here, I've asked managers to actually schedule nurses that have asked to be involved. I said, can you schedule them for 2 hours of their shift every, however many weeks to work on this? And that's been a tough sell, and I haven't had very much success with that. But that's something you can try to see if there's a way that they can make that part of their educational development. So there's actually the time dedicated, so it's not just sort of this afterthought on the side of their desk. But I would say my primary message would be pick something that your team can work on that matters to them.
Thank you.
Alternatively, I agree. I think the policy issues should come from the nurses. I think they should inform which issues are addressed, but I'm not sure they have to do all the policy-making work.
Right. Well, this question is related to that, I think, and it's for Gina. It's this question from Berlanda. There's a heightened call to action for nurses and others in giving voice to some of these issues in the public domain, for example, through the media, and Gina, you mentioned that earlier on in the call. But the question is, what ideas do you have for frontline nurses to do this within the context of organizational constraints? And I would assume related to that, the demanding role that nurses already have within the system.
Well, I appreciate they have demanding roles, but there are leaders within nursing that are still on faculties, rewarding faculty for getting published in journals and not published in papers. So I think we should shift the kind of publication we want. And that role doesn't have to fall to everyone. You, of course, want the journalist to be interviewing somebody with known credibility and so forth to have impact.
Right. That's a very good point. There also is there is a network across the country that CHSRF is affiliated with called the Evidence Network, and which is a series of experts who commit to responding to media, being very proactive in getting op-eds into media in various ways on a variety of health policy issues, and activating nursing leadership with the network could be very helpful in both getting out some of the kinds of data that you presented today, Gina, but also some of the recommendations around what nurses can be doing to better address the health needs of the population.
Once again, I am part of the Op-Ed Evidence Network with Narlu Ruse and others out in Winnipeg. For example, that system could empower their writers to take evidence that are written material I have and then distill it in a journalistic way to be an op-ed. But it's hard to ask one person to write in every possible way. But even publishing companies have copy editors and those sorts of things.
I'd like just to add another point to go back to a point I made earlier on that question is you need to invest a bit of time to figure out how the decisions are made in your organization and figure out how to work within that. That's a bit of a reality. But if you figure out, what the committees are or who the decision makers are, and you understand how that process works, it makes it easier for you when you have an idea that you want advanced in how to actually make that happen.
Yeah, but we have to admit, Scott, there is ideology that no amount of evidence will ever deal with. It needs political will.
I agree.
The ideologies that everything needs to be physician-led, for example, seems to be impenetrable. Except it could be changed by the funder.
Right. This question, I think I'll throw it out there and see which of you are most interested in answering it or both. I'm a manager in this one from Nina. I'm a manager in the new School of Mental Health and Addictions program through the CCACs. We are in the process of hiring registered nurses, and there has been a suggestion to hire a mix of registered nurses and RPNs as funding is limited. Do you see an expanded role for RPNs in Ontario, and do you see this contributing to a dilution of the RN role?
My own feeling is that everybody is moving up their role, and I need advanced prepared nurses to do even more, and then I need nurses to do more. Then RPNs can do more. I really am big on the personal support worker being able to do more. So there are many capable people who could do more. So I don't see it as a dilution. I see it as a freeing up in order that more can be assumed.
Right. And Scott, do you have a perspective on that one?
I would agree entirely with Gina. It's always a challenge when you have a staff mix with different people and different professions, and defining the roles and making sure. I think the challenge becomes more within your staff mix, making sure that everyone is working to their full potential, and there is that understanding that if I give, it's not about giving something up, because nurses are bad at this too. We hold on to paperwork. we fight over that with our LPNs. Oh no, I'm filling out that form. That's my job. But I would frame it in, what can you gain if I give up this? If I give this to somebody else to do, what can I do better? What can I do more for my patient and for my profession?
But to see more deeply into this problem, I'm currently working on having a nurse practitioner in schools rather than a mental health nurse or an RPN. I'm making the point, since I work in primary care, have for the past 40 years, a child is not going to come to a nurse and start talking about mental health problems. Only 16% of youth with mental health problems talk to an adult or a professional. So we need the nurse to be able to lay on hands and do things. And youth will bring their sore throat or their earache to the nurse, check her out, and then let all the rest of the student body know. We're piloting this in one of our downtown schools, where 32% of the youth are immigrants and don't have family physicians. And it's working beautifully, as is the snowball effect that I'm just talking about. But the ministry, as the questioner is making the point, didn't have the money, so they say, so we'll hire RNs and RPNs okay, but now that there's going to be just so few of them, that what's going to happen, they're going to work at a high level and plan. So still, we don't have anybody that's delivering the service. Mm-hmm. I think that's really unfortunate.
Yeah, and this comes back to the need for us to be able to define in tangible ways how that value is, like how that saves money, how that improves the system. We have to be able to be very clear about how that happens. And in terms of, and what I've learned working with CHSRF on our chronic disease management project is that evaluation isn't an afterthought. Evaluation is an ongoing process, and I think that without getting into too much detail, because I know that my colleagues at CHSRF could discuss this much better than I can, but that commitment to that ongoing evaluation process in terms of how to show your value is working very well for us in advancing a very difficult change in our system, or a very big change in our system as we move along. So that's a side piece for you to think about, but certainly if you're interested in more of that, talk to the folks at CHSRF about those concepts and how you can use that ongoing evaluative process to help to move your system.
By the way, the rollout of that particular policy has upset school boards terribly, because the insinuation is the Ministry of Health will now give nurses to school boards so that mental health can be addressed. And it ignores the fact that the Ministry of Education and the Ministry of Children and Youth have other initiatives for mental health going on. So it's just another example of big health brother telling other people how to work.
Thank you for that. And Scott, to pick up on your comment, if people are interested in hearing more about evaluation here at CHSRF and our approach to that and how we can work with you, please don't hesitate to contact us. Another question here from Wesley. How has the expanding role of nurses in the provision of care translated into an expansion of the profession's scope of practice?
Well, go ahead.
Great question. I think that it's evolved a bit differently around the country, but certainly in the North, our nurses started out in an advanced role because they had to, and as sort of things moved along, I think as time moved along, I think it was in the late 70s or early 80s, there was a formalization of that, a recognition that, hey, we have these nurses doing these things out in remote areas. Well, you're doing that in the North, but we could also see that the need for that in other parts of the country. So how do we formalize that? And then it was the Dalhousie program, the Advanced Nursing in-Service program started, and that ran for a number of years. And then when nurse practitioner education started, that program went away and it evolved into that. So I think it's been the recognition that nurses are doing that anyways, and so it's a way to how do we expand that? How do we scale that up? And it's been through, I think, a combination of people saying, that's a great idea, but we want to train other people to do what you're doing, so then it gets worked into the nursing education system and has evolved that way.
I agree with that, Scott. One thing, though, I just can't miss is we have to look at the rollout, how this nurse practitioner is paid, and it keeps being funded through physician groups, who then in turn tell the nurse practitioner how to practice. I've worked for 37 years with nurse practitioners, and the physician groups want them to see people once every 4 minutes, just like they do. So there's a lot about the payer. Who pays controls the function.
Well, this question is actually, I think, a good pickup on what you just said, Gina. This is from Wendy and Christina, and the question for you, Gina, is, do you think this is in Ontario, do you think the provincial funding for family health teams in Ontario versus family doctors paying nurses are a move in the right direction for optimizing the role of primary care nurses?
I think it's a move in the right direction, but it was in the National Post paper that some of the issues that can be going on in some family health teams are that they're just not able to fill that nurse practitioner role. And then they saved that money that year and gave physician bonuses. So there's a lack of oversight, to make sure that physician groups are doing what they have been funded to do.
I don't know much about the Ontario model. In the Northwest Territories, almost all of our physicians are salary, not fee-for-service, as are our nurse practitioners. Our nurse practitioners are paid directly by the health authority, not by the, not through a physician group.
Well, that's great.
And there's been there's a growing, small but growing amount of research being done on that model in the Northwest Territories and how that has impacted care and quality of life for physicians and our ability to recruit.
Mm-hmm. Of course, Ontario has launched and did start nurse practitioner clinics that need to be run and regulated by nurse practitioners in collaboration with doctors.
Mm-hmm.
Well, this leads to two questions that we have, I think, that I'll put together here. So the first one was from Nolan, which was basically, I'm just going to paraphrase the question here, we seem to be able to enable nurse practitioners to practice at full scope of practice in the north or rural and remote areas, but not in urban areas. And why is that the case? Is that a double standard? And then this question from Arlene, which says, yes, everyone can do more, but it depends on the situation, patient acuity and staff component, example, the education and experience. The sad reality is the only place where the RN can do more within the physician-led model is in the north because there's no physician. How do we begin to change this? So this issue of enabling nurses to, especially nurse practitioners, to practice at full scope of practice in remote areas or rural areas, but not in urban areas, and this seems to be working in the north, but not elsewhere. How would you?
I'll start with that one because you're entirely right, and the north is not immune to that. Because in Yellowknife, where we have a large physician population, there is certainly resistance to having nurses and nurse practitioners in an advanced role. It has evolved, though, and it does evolve, and it's not going to happen overnight. But what we've seen is a shift from, no, that can't happen here, to, okay, well, I guess it's okay if nurse practitioners or community health nurses do this, or public health does that, to, okay, well, they did that well, so, and that allowed...
Their salary, though, Scott, and they're not losing income. Perhaps,
yeah, and I don't know the data behind that, but nonetheless, I believe that even though there's a money driver behind that, there's also a practice drive behind that, because I don't believe that our physicians or anybody wants to be doing work that isn't challenging them, that isn't what they were trained to do. So I think it's that constantly moving up of everybody. So it is an evolution process, and even though we have to start in remote and rural areas, I think it does evolve over time to permeate into more mainstream practice.
Just to add, we have to change the whole way the whole service system is financed to create the incentive to want to use all the disciplines appropriately. Okay, so if you have a fee-for-service physician, which we still have, then you don't really want a nurse practitioner because that cuts down his billings. In the emergency room, I went to one of our CEOs to say, look here, look how all the young people's emergency room visits are coming from this area of town, and they're using your emergency room the most. You could put a nurse practitioner in there and cut wait times in half. And the response was, Gina, I am not taking on the OMA. I'm known for saying the unsayable.
Well, and I feel bad because I feel like we've said, yeah, it's a problem, but we don't have a solution, because I don't know that there is a quick fix to that, because
there is a quick fix. The way everybody is funded, it has to be back to the electorate, the elected official.
Right, but making that change happen is not, what I'm saying is that may be the solution, but it's not easy to get to that solution.
No, I know, and that's why everybody's talking about disruptive leadership.
So then I'll put the question back to you then. So then what's the next step action for nurses to move that ahead?
We need a provincial government to want to fund models of this care and to hire them, as with the nurses in schools, to roll that money through an organization like home care, so that home care hires the nurses to do what they want them to do.
But wanting a provincial government to do something is not a nursing action. What would be the first step that you would take from a very experienced researcher's point of view into some more immediate actions for us as nurses? Because I think that's a challenge. We recognize that, yes, it requires political change, and that's a longer-term process, but that seems to be outside the realm, the tangent of our daily scope of influence.
Well, see, that's why I'm talking about the tipping point. The time is now. The province's budgets are bankrupt. It's now. And so now we have this wonderful coalescence of our desire to do this and the need for it.
And I agree, and that's why I think that we need to be able to, though, articulate our value in a quantitative method, in more quantitative methods, and even in small ways that show, here's how we save money, here's how we improve care. But I really, unfortunately, and I hate to say this, but it's the reality, because I work in the political system, and I know how the decisions are made, and it always comes down to money. Almost always comes down to money.
I'm glad you said that. It's always money.
And we have to, whether we like it or not, we have to be able to translate what we do and our actions into how we're going to save money in the system. And I think nurses are very reluctant to have that discussion because it is uncomfortable. We think it goes against our values of providing care, and money shouldn't matter. But we have to start thinking, how do our nursing values, how's our nursing expertise translate into cost savings for the system?
Yes. Well, we have provincial nurse leaders, and the CNA and others, and even CHSRF, have influence also with high-level decision makers, and they have the evidence now, have had it actually for 40 years.
So there's some very interesting takeaways so far from the call, some of them around how we get information out there, how we, doing the research, pulling information together, the channels by which we get those out there, whether through media and journals, etc. And for organizations like CHSRF and others to be synthesizing that information, sharing it, and bringing it to the attention of policymakers. So I think that's very important, I think, takeaway message from today's call. This question is from Linda, and it's related to funding. So I think we'll keep on that train of thought here. And Gina, it's for you. It says the funding model is critical, both to support independent NP practice as well as supporting interprofessional collaborative practice. How do we work with the system to address the prevalence of the fee-for-service system for physicians?
I think the province should stop having it. And they're slowly progressing doing that. They've moved to the family health team model. Before that, we had the health service organizations, then the community health centers. Those were all salaried physicians and funding interdisciplinary team. Now we have the family health team. More and more physician groups are getting into this, and I just encourage government to continue doing that.
I think that I agree with you, Gina. But I don't think that the medical associations are. I think I know they're having the same conversations. I have these conversations with my physician colleagues, and certainly the CMAs have these very conversations. I think that we need to talk to each other about it. And when I say we, that can occur at your local level or at your provincial level even, to say, look, there's only so much money in the pot. How do we make this work? And I think that we can't exclude having that conversation, even though it is uncomfortable.
Yes, I think we should have that conversation as well. There's a thing called the medical home that the Canadian Medical Association in the U.S., that the Canadian Medical Association is espousing. That would be great. Well, it's simply home care proactively and comprehensively provided by nurses. I'm just reading all their information and thinking, not in one document is the word nurse mentioned. So I was at a CMA function representing the Canadian Institute of Children's Health, and they were making the point CMA and CNA agrees on the principles that should guide healthcare provision. But now they wanted to get onto measures of the principles, and their indicators were very medical and not at all about the social determinants of health.
And those are always exceptionally difficult to measure and quantify, unfortunately.
The social determinants of health?
Yes.
Oh, I don't think so, that it's that hard.
Well, I think that in how you maybe I should clarify that. It's difficult to translate those into easier solutions, because we say that by having clean drinking water, it's going to impact your health for your lifetime. Whereas I think that the more quote unquote medical measures are very acute focus. Like it's hospital length of stay. It's readmission rates. It's amputation rates. But they're very, very short focused, and they're easy to address. They're easier than social determinant issues to address, rather than longer-term issues and longer-term investment to see the changes in social determinant of health indicators.
Oh, I see where you're going. The CHSRF paper that I authored with CNA is not measuring that. It's not measuring those as outcomes. We're measuring healthcare utilization, emergency room and hospital utilization, and the role of the nurse in those trials had to do with supplementing physician care, the on-demand physician care. For example, if you have an older person at home with a bit of dementia, living alone, they don't problem solve as well. They're going to forget their medicine, and they're going to present to the ER. So that's what I'm saying. Our current on-demand system, if you ask, kind of thing, acute care model is a poor match to our new scene that we have.
Yes, I completely agree, and I think that everyone on the phone agrees too.
Yeah, and that paper, just to reiterate, that paper is on the CHSRF website, www.chsrf.ca/on-call. I mean, this probably will be our last question, and Gina, it's for you, and it's related to something going on in obviously in Manitoba right now, so I think it's worth having you comment on this from Eleni. Gina, we're looking to integrate RNs into physician clinics to engage physicians in developing the model. What roles for the RN are supported by evidence, or would you recommend?
I recommend the expanded, proactive, comprehensive role of a nurse so that she's doing what she does best. Okay, my whole thing has to do, the physicians will be happy if some other funder is giving them nurses, then they won't balk. But if the money is going into physician clinics to pay for the performance of nurses, then it won't work. Does that answer it?
I think it does. Scott, would you have a comment on that, based on your experience in NWT?
Yeah, I don't know if this would work because our funding model is different, but I've worked in health centers where your first point of contact is always the nurse. If you want to see the physician, you see the nurse first, and the nurse does whatever he or she can for you, and then if it's beyond the scope or requires consultation, then you're handed off to the physician. So the nurse in our system, well, outside of our, basically of our major centers, our nurse is the entry point to the system, and they're the ones that provide that initial assessment and do whatever they can first for the person before they get escalated up. So if there's a way to do that, like if there's a way to, with funding models, I think it requires a bit more thought. It's not impossible. But I think if you sell that as a value, because I don't think your physicians want to spend their time taking out sutures, giving routine immunizations.
But they do want to make money.
Right. So if you want to sell it to them, if that's how you think it is, if you think that's the way that you have to sell it, then figure out how you say this is how you make more money by putting your nurses as the front line to look after, the 80% of stuff that doesn't need to come to you, or whatever percentage that doesn't need to come to you. Find a way to sell the value to that. And I don't know if the more complex stuff is a higher billing rate. I don't know enough about about billing at the provincial level.
Well, there's great uproar in Ontario about physicians' fees being frozen. I have two things. Even if you paid a nurse more money, even equal to what a physician is paid, the savings would still be there in reduced emergency and hospital utilization because she practices in a way that supplements and is aimed at other determinants of health. So I wouldn't try to be helping them make money because that's precisely the problem we're in. We're bankrupt.
It's probably a good place to end. I'd like to thank you both very much. We have been thrilled to have so many questions coming in, and we're just unfortunately not able to get to them on the call. And if your question has not been answered, we will be sure to get these to our speakers following the call. With that, this concludes the 5th season of On Call, and we'd like to thank everyone very much for your continued support and participation. And stay with us over the summer as we will come online with another set of On Calls starting in September. In the meanwhile, we encourage you to watch past sessions on our website. Again, that's www.chsrf.ca/on-call. There are many, many interesting calls this year. If you have missed some of them, you can podcast them on our website. We would also encourage those of you who are not signed up for our electronic newsletter at CHSRF to stay up to date on all of our activities, including these future on-calls. At this time, I'd just like to extend a sincere thank you to our speakers, Gina and Scott. And if you'd like to connect with our speakers directly, we encourage you to do so using the email addresses provided. That concludes today's call. Again, thank you so much for participating. And again, Gina and Scott, thank you so much for your help today.
Thank you, Steve.
Thanks, everyone.
Thank you. Ladies and gentlemen, this does conclude your conference call for today. We thank you for your participation. You may now disconnect your lines and have a great day.